So I'm now very pleased to introduce our fourth speaker for today, Professor Elif Ekinci. Professor Ekinci is the Sir Edward Dunlop Professorial Fellow in Metabolic Medicine at the University of Melbourne. She's a clinician researcher and academic endocrinologist in the field of diabetes. Her research is focused on the detection and management of diabetic complications and undertaking observational and clinical trials. She's the inaugural director of the Australian Centre for Accelerating Diabetes Innovations and is also the head of diabetes at Austin Health, where she coordinates the clinical care of inpatients and outpatients with diabetes. Professor Ekinci has received multiple awards for her work, including the Australian Diabetes Society Ranji and Amara Wickramanayake Clinical Diabetes Research Award, given to leading early and mid-career diabetes researchers in Australia. Please join me in welcoming Professor Elif Ekinci.
Thank you. Thanks so much for the invitation, Ingrid and team. So I'm going to talk to you a little bit about my journey in all of this and how I've tried to make sense of it over time. But before I do that, I just want to acknowledge my team. This is my immediate team at the Austin. Actually, it's bigger than that now, but and we work really. It's a collaborative, very collaborative team. With I think the importance here is that as a clinician scientist, you really need to look after your team and so they can trust you, and then you'll have a long and successful relationship with them. And sometimes they might leave, but you can continue to work with them, which is fantastic. And the other team that I work with is through the Australian Centre for Accelerating Diabetes Innovation, which is a new centre I lead. So as an overview, so I'm a clinician scientist at the University of Melbourne, and my story really began, my family migrated to Australia from Turkey when I was 11, and so I grew up in Melbourne, and I went to medical school at the University of Melbourne. But the reason I wanted to tell you that is sometimes when you've had a big migration in your life, you actually don't want to go anywhere else. You just want to stay here, and you realise the importance of that for your children too, the stability and so forth. So I've got 3 kids, and I knew from the outset that I wanted to really stay in Melbourne in one place and then do my research and work from here. But the other thing I wanted to say is that so much is possible really from Melbourne or wherever you are because of the things you can do. And one of the things I did was when I was at medical school, I received a John Flynn scholarship, so I was able to go to Maningrida, which is in Arnhem Land, and I went there every year for 4 years, and the community there were absolutely brilliant people. They were just so welcoming and just really kind, and I was really welcomed into the community and just learned so much from the Aboriginal people of Maningrida. And this is one of the planes that we used to catch. And the reason I want to show you that is I've come back to, now at this stage of my career now, I'm actually collaborating with the Royal Australian Flying Doctors coming back. And I think it was a good investment the government did years ago for that John Flynn scholarship, because a lot of what I've done is actually from those early experiences. So what I learned in Maningrida, which is the Kunibiji people, they're the traditional owners of this country, and it was a really beautiful place because it was established as a trading post, but it was really thriving in Aboriginal culture and languages, and probably one of the most linguistically diverse areas in the world. And this is just some of the fishing we used to do on the weekends with the Aboriginal community. You can see, with all the elder women in the community who welcomed me and really made me part of the community. And I guess what I wanted to share here is that, it was a beautiful country. However, what I saw with that experience was that young people were developing diabetes complications, and, it was sort of more rapidly. People who had lived on the land for many years, suddenly they were exposed to white flour and sugar and so forth by the westernisation that was happening, and they were developing rapid and florid diabetes complications, including diabetic kidney disease, people needing to go onto dialysis in their 30s and having strokes in their 40s. That was sort of a bit heartbreaking for me, and that experience really has driven my work. The other thing is that I think this is relevant not just for Aboriginal people, but any community that we look after. Obviously, we need to think about this concept of health infrastructure. So what are the things we need to ensure that people have, adequately? And so that includes obviously housing, health literacy, essential services, healthy food, water, and health improves with these improved socio-economic standards, income, employment and education. Subsequent to my experience, I have continued after my PhD to work in Aboriginal communities across the country more. I worked as a postdoc at the Menzies, looking at the methods of trying to improve kidney function measurement, but and also subsequently as an endocrinologist with the Baker Institute. I visited a community there for 7 years, and what I saw was how difficult it was for people to have access to fresh food and produce, and how expensive that was, and how few opportunities there were in the communities, especially during the heat, in terms of physical activity and exercise. So I learnt, and I continue to learn a lot from community. And the other thing I wanted to mention is this concept of institutional racism, which I've observed sadly in Australia, which unfortunately continues. And just a message for you all there is to really sort of take note of that and the biases that exist in our current health structures, which really limit people from Aboriginal and Torres Strait Islander people, refugees, people of non-English speaking backgrounds, receiving better health outcomes, and also securing long-term employment or gaining education. So after I did medical school at the Austin, I wanted to, we did some travelling with my partner then, and who then subsequently became my husband, came back to St Vincent's to do my clinical training to become a specialist. And then I wanted to go back to the Austin where I sort of did my medical training. I really enjoyed and missed that environment, and I wanted to work with my PhD supervisor, who's, you can see here, Professor George Jerams, who was at the time when I was doing my training, he was coming to the end of his career, so I was his last PhD student. But I learnt a lot from that experience with him, in particular in diabetic kidney disease, which is kind of the reason why I went there in the first place, was because of the impact I was seeing in diabetes. And in my in the medical training, as you know, as a junior doctor, and also on the wards as a young doctor, you see so much. Some of the sickest people in the hospital are people with diabetes complications, having dialysis, having coronary artery bypass grafts, amputations and so forth. So I really wanted to work in that field, and I came to work with George. And I learned a lot about leadership from him, and how to be a good leader, and that includes listening to your students, to your staff, really. I'm really passionate about ensuring that young people's voices are heard in meetings and so forth. So I really would encourage you to really speak up at meetings. And I say that to my PhD students as well. And it's particularly important for me, like having had 3 kids and COVID, I haven't had the opportunity to travel, so to advance my career and to develop those international collaborations. Whenever I go to an international meeting, I try to put my hand up and talk to colleagues and really interact, and I recommend that to all my team. So in terms of what I do, I guess the reason I wanted to share this with you is one of the best things about being a clinician scientist is the ability to train the next generation of people, and including the advanced trainees in endocrinology and diabetes, and also the younger physicians. And I find working with the younger team members really joyful, and I learn a lot from them as well. So I really would recommend you to find people that you can, as the previous speaker said, have mentorship opportunities, and that doesn't necessarily have to be in your field. So what subsequently happened after I did my physician training was I subsequently continued to work in diabetes complications, in particular in diabetic kidney disease. Also wanted to really bring back My work really evolves around now trying to get health equity and access for people. For example, if you go to private practice in Melbourne and you have type 2 diabetes, you can have access to lots of different medications. However, from my personal experience, and now we provide a service to Rumballara and Shepparton to the Aboriginal community, but also in the outpatient setting, the access to both technologies and the drugs are not there for people for various reasons, and it is to do a lot with the socioeconomic situation and health literacy. So I really wanted to start to develop these long-term relationships with communities, so that we can translate some of the work that some of the research that we're working on in tertiary hospital setting, and how do we get that to communities. And one of the projects which was, you can see my team here. So Mariam Hatcham, who's my PhD student, she's the project coordinator for this large study, which is now over 20 communities across the country. And I was always told, you can't really do clinical trials from Melbourne in communities, it's just not possible. How do you get the engagement? How do you do that? And so what we wanted to do was actually try to model ways of doing clinical trials where we do get really good engagement, and we do this as our team. And you can see Ray Kelly, who's my other PhD student. He's a Aboriginal exercise physiologist. He was on the show with Michael Mosley a couple of years ago on diabetes remission, and he's joined our team, and he's doing some amazing work in communities. That's my other PhD student, Audrey, in the middle. She's a clinician-scientist. She's working the high degree, and the opportunities has now enabled her to have a position at Goulburn Valley Health as well. So really trying to improve health for Aboriginal, for not just Aboriginal people, but for people in rural and remote parts of Australia. Belinda Moore, who's also a master's student, she's going to do a PhD. She's a wonderful nurse, diabetes nurse educator, and she's really passionate about implementation science. And Tracy Hearn, who's our Aboriginal research assistant there. And so with these great people, we meet regularly on Zoom every week. We can conduct this amazing trial, which is recruiting fabulously. It's actually recruited over 150 people in a short period of time. And I'm just going to show you I thought you might find this interesting, but one of the ways of trying to obtain consent we wanted to develop, this is in collaboration with Luke Birchall, who's an Aboriginal cardiologist, is this. So I'm just going to let you watch this, and this is by an Aboriginal artist who designed this video.
Diabetes is a major challenge for us Indigenous mob. So we've been looking for a better solution than finger pricking, one that gives us a picture of what's happening to our blood sugars over time. Flash glucose monitors are a new technology designed to track your blood sugar levels continuously and can send updates to either your phone or a special device reader. The monitors look like a round patch that just sit on top of your skin, with a tiny painless sensor that just sits below your skin. Right now we're putting together a study that aims to find out whether flash glucose monitors are better than finger prick testing for managing high blood sugar levels in Aboriginal and Torres Strait Islander people living with diabetes. Research using flash glucose monitors has been done in other communities, but this is the first study designed specifically for our mob by our mob, because it's important to find out if this new technology works for us or not. If you'd like to be involved, here's how it all works. There are 6 visits over 6 months. Visit 1 will take some of your blood and urine to understand your diabetes. Visit 2 will provide you with a special type of flash glucose sensor, which you'll need to leave on for 2 weeks. Visit 3 will then download and review the information collected by the flash glucose sensor. After the first stage of the research project, you'll be randomly put into one of 2 groups. One group will continue to wear the flash glucose sensor, while the other group will go back to finger pricking. This is so we can compare to see which method is better. After 3 months, we'll see you for visit 4. This is where we'll take another blood and urine sample to see how your diabetes is going. And we'll see you back again for visits 5 and 6 just to check up on how you're going. The information collected from you in this study will help researchers understand more about what Aboriginal and Torres Strait Islander people need to better manage their diabetes. We hope it will also lead to better funding and diabetes care pathways for our mob. If you have any questions or concerns, you can now raise them with your clinician who is showing you this video. Remember, the decision to participate is your own. Should you choose not to participate, this will not influence your care in any way. We hope we can work towards finding solutions to diabetes for our mob and make a difference.
Yeah, so this is just an example of how, you can actually, that video was shortlisted for an award in Europe, and actually other sites across the country are looking at using consent videos like that. So I think it's where you can be really creative in medicine, and we've worked with an amazing Aboriginal artist and who's enabled us to do this. So that trial is going really well, but I just wanted to highlight that it's the long-term relationships that are really important, I think. And so the amount of effort and what effort you put into something, if you can make it that you can continue to have this relationship. So now when we ask for the next trial, the communities are very happy to join us because we've made that initial engagement effort. So the other thing I wanted to talk about is ACARDI. So this is I guess a point in your life where you think, oh, so there's an opportunity like this. For me, it was when they announced this bid, which was like this large, probably the largest bid the government has invested in diabetes. I said, oh, this is right for me. Like, this is the one I'm going to go for. Work really hard. Complications. It was all around complications, all around what I am really keen to work on. So it was really great to bring together a great team of people to work on this. So I guess it's an innovative ecosystem is a way of describing it. So our vision is really to try to accelerate the development of new products, new drugs, new technologies, in vitro diagnostics and so forth, and as well as devices for people with diabetes complications. And the three biggest complications that it came from a needs analysis which was done. So it was diabetic kidney disease, foot ulcers and amputations, and those acute complications that bring people to hospital. Well, those complications actually is, as you know, in the wards, they're the sickest people, right? So our centre has funds 18 projects, as well as it funds the training program for the new generation, and it has a national reach. It's very highly collaborative, and what we're trying to do is really to have these enabling platforms. So for the funded projects, but also any new projects that come along, like health economics, implementation, co-design, biostats, behavioural, and we really work very closely with our Indigenous advisory, community advisory, training program advisory, and we've got an independent scientific and commercialisation advisory and international advisory group. And we have multiple projects that are working, but this year, for example, 2 other projects have joined our portfolio from independent other research funding. And it's also really important to work for people who are good people, I think, and just stick to those relationships, work with good people, work with people who are passionate about what they're doing. I'm fortunate to work with Sue Alberti. I've learned a lot from her. She's a lovely lady. She's her daughter died from type 1 diabetes complications on a plane, and she's very passionate about the work that needs to happen for type 1 diabetes and its complications, or any diabetes complications. And she's a very well-known, strong person in society, and she's very helpful. So I think having those connections and maintaining, mentors who are not necessarily within your field will take you a long way. And this is, you can find out more about our centre. And I'm just going to show you this. We spent a lot of effort developing these videos as well, online courses at Melbourne Uni, which, because the field of diabetes is changing so rapidly, I was thinking at nights, how are we going to get all this education out there? But if you wanted to do a short course, it's through the University of Melbourne. You can check it out there. That's it. Okay.
Thank Thank you so much. We'll move into a Q&A now if anyone has any questions. And if anyone's online and wants to ask questions, please just send them through.
Thanks for the talk. What would you say are the biggest roadblocks for health equity for Indigenous Australians?
I think the communities I've worked in, it's the remoteness and also the rapid turnaround of healthcare providers. And so then, unfortunately, you know, Aboriginal people have to repeat the same story over and over again because the nurses just change, the doctors change, and they don't have those long-term, you know, trusting relationships. So for what we were doing, it worked really well because we would go every 6 months, or what Audrey's doing at the moment is going regularly. The one person goes to the one community to develop those relationships. That, I think, has worked well. The other thing is there is data showing that the more remote you are from tertiary centres, your access to the latest, you know, evidence-based medicines are not so good compared to people who are in tertiary centres. So this is sort of my passion for, like with the CARDI as well, what we're trying to do is how do we get the information out there to, you know, primary care physicians. And one of the projects we're working on is actually with Royal Australasian Flying Doctors for the same reason, because the people who really need help don't get that help, and really they're very sick by the time they're transferred. So,
Thank you so much for the work you do.
If there are no other questions, we might call it there. Thank you so much, and please join me in another round of applause.